our plan called Power, Preoperative, Wish, Engagement, and Readiness. So what's the problem? 1 in 5 older adults will have a major life-altering complication after high-risk surgery. Post-operative complications increase 30-day mortality by 6-fold compared to younger patients having the same procedure. This is going to precipitate loss of physical functioning and independence and lead to nursing home placement. And in fact, less than 10% of these patients actually have named a healthcare agent or have an advance directive. Yes, that's right. Our patients' families and our care providers are in the dark as far as what our patients wish with this unexpected complication. Our current goals. Number 1, we'll have patients identify a medical decision maker prior to surgery. We'll have the option of making it legal via a formal healthcare power of attorney form. Number 2, we'll give patients the option to fill out advance directives prior to surgery. And number 3, we'll develop protocols to identify those patients who would best benefit from our services.
The power team would consist of a supportive care nurse, anesthesiologist or perioperative care physician, chaplain and chaplain residents, volunteers, and medical students. All team members would be trained in the respecting choices course. Phase 1 would include all elective surgery patients. Everyone that goes to surgery in our institution gets this packet. But in this packet is a couple sentences about advanced care planning. We will change that. We will put in information on discussions about how to pick a healthcare agent. We will borrow from the Mayo Clinic and several other large institutions that are already including some information on values and goals. We will include a link to Emmy, which is already in our system. It's just underutilized, about videos about advanced care planning, and we'll have links to other advanced care planning documents. We will also include advanced directive forms in My Wake Health for those people that just want to go in there and download them and have them notarized. And then we will also educate surrogates and medical decision makers in how they help the patient make their medical decisions. A surgical navigator will follow up by phone call and ask if they have any questions about anything in the packet. And then we will document a medical decision maker. That is something that we are not doing for these surgical patients. We will have documented medical decision makers for everybody. We will also offer options to formalize their advanced directives, so our power facilitators can do their healthcare power of attorney. Faith Health can be done outpatient or inpatient, or we can have them make a appointment with their primary care physician if there's time before their surgery.
Next, we will focus on phase 2, which will first focus on patients undergoing major oncologic surgery. These patients are going to be seen in our preoperative anesthesia clinic. So once they go through their routine PAC evaluation, they'll be then guided to meet with one of our power facilitators as part of the power consult. Here they will go over with the patients, filling out the forms, if they so choose, to fill out for their healthcare power of attorney, also potentially their advanced directives. We will also sit down with them and go through the MAT, which is a self-assessment tool of a patient's mobility. And this will help the patients understand their baseline function and their potential trajectory after they have a major surgery. All of this will be documented in EPIC under the Advanced Directives tab. And finally, we'll move to phase 3, which we will then re-engage with the patient, their family, and the provider 72 hours post-surgery to go through everything that we have discussed above and to make sure what we are doing is in line with the patient's wishes.
Here at Wake Forest, we look at self-reported mobility, or the MAT-SF, as a marker of function and physiologic reserve. The MAT-SF is 10 computer-generated animations depicting mobility in various environment. So this has been validated among community dwellers against other measures of function. On the right is just one example of the 10 vignettes. The patient would be asked the question, for how many minutes could you walk through rocky inclined terrain at the faster pace shown without stopping? The scores on the mat range from 69 to 30, 69 being excellent mobility, 30 being poor mobility. We've tested this already in our pre-op clinic, looking at 200 patients going for non-cardiac surgery. We found that those had intermediate to poor mobility, had this associated with longer length of stay, early complications, and need for nursing home placement. So we're hoping to use this actually to begin our discussions for advanced care planning with these patients.
So our expected outcomes and measures of success, we expect to improve provider and patient satisfaction by carrying out our patients' wishes and goals of care, decreasing provider burnout, decreasing the length of stay in the ICU and increased hospice in place conversions, decreased ventilator days, and educating allied health professionals and community members about advanced care planning. The timeline for our project: between May and July of this year, we'll have focus groups. The focus groups will consist of our stakeholders, which you can see over here on the right. So that includes surgeons, the surgical intensivists, SICU nurses, supportive care nurses, anesthesiologists, surgical navigators, social workers, chaplains, palliative care, legal team, patient advisory council that can help us with wording and things like that to make sure we're sensitive to patients, and then patients themselves. The focus groups will help us to figure out the forms that will go in the packets that patients get in the surgical clinics, as well as helping to write a script for our surgical navigators. We'll also have to do some education of the staff, including presenting this at grand rounds so the surgeons are aware of what's going on, so that they can mention to the patients when they come to the surgery clinic, hey, someone's going to be talking to you about your advanced care directives, as well as educating the surgical navigators as to what that script would be when they did the phone call. In August, we do training for our power team. This would include the Respecting Choices course, which is an 8-hour-long course. September, we'd like to implement our plan, and then in December and March, we'd like to review how we're doing so far, see if any changes need to be made.
We have identified and thought about some potential barriers. Our first would be our surgery buy-in. The thought is possibly that another group of providers is speaking to the surgeon's patients, but again, we would provide education to the surgeons about the idea of what we're doing, as well as having them to have the conversation during their pre-op visit. They may have some concern about cancellation of elective surgeries, and we will be able to track that. Space. There's always a concern about where you will sit down and talk with a patient. We have determined that in the initial portions of this program that we will narrow our focus so that space should not be as much of an issue with the number of patients coming through. Where do we go from here? While this begins as a narrow program, our expectation is to expand this and extend it to patients undergoing non-oncological surgeries. We also want to expand this to our satellite hospitals, including in Lexington and Davie. Our community outreach portion, the power team will develop 1 to 2 slides that can be added to outpatient talks that our surgeons may provide throughout the community. Marketing. We at Wake Forest would like for everyone to choose to have their elective surgeries here, and they can with the power team.
So please help us to put power into person-centered perioperative care.
Having surgery?
Who's your person?